Good day. Welcome to another CHRO South Africa webinar. My name is Sungula Ngabinde, and I'm the Community Manager for CHRO South Africa. I'd like us to please introduce ourselves as we come into the session. Just make sure you switch your in your chat box to address your comments to the panelists and attendees instead of to panelists only, so that all your colleagues coming into the conversation can also see what you plan to discuss. I'd also, today we'll be discussing a phenomenon called long COVID. You know, while the incidence of COVID-19 infections may be on the wane, many people continue to experience various symptoms long after they've recovered from the virus. In some cases, people develop new symptoms post-recovery, and this phenomenon is dubbed long COVID, which sees people experiencing COVID-19 flare-ups or continuous symptoms of illness, from fever to headaches to insomnia, which is the loss of smell, and fatigue as well, long after they have recovered from the virus, so to speak. This extended period of illness has implications for employers, not only because of employees' productivity being hampered by long COVID, but also because there are implications for health risk benefits and their costs. Joining us in this conversation today are Myrna Sachs, who is the Head of Health Management Solutions at Alexander Forbes, and Dr. Salim Ahmed, Occupational Medical Consultant at Life EHS. Thank you to both of you for availing yourselves for the discussion, and thank you to all of you who are joining us today, wherever you are. And let's get right into it. Dr. Salim, I'd like to start with you. Please provide us with like an overview of how you outline the long-term, long COVID challenge to be.
Thank you, Singula. And good morning, colleagues. And the topic of long COVID or the long-term health effects of COVID infections are definitely an area of concern and growing interest, as yet also getting a lot of scrutiny from the medical side and more interest in it as well. So my name is Dr. Salim Ahmed. I'm an occupational medical consultant for Life EHS, and our topic today is going to be on long COVID. Just going to go to my next slide. Sorry, just for a second here. Yes, so we've got laid out a little agenda for today. We're going to do a little introduction to myself, look at some of the definitions of COVID-19 as well as long COVID, try and get a sense of the scale of COVID-19 and long COVID, look a little bit at the clinical presentation, and talk a little bit about management. So in terms of a little introduction to myself, so I'm a medical doctor qualified for here in South Africa. Three key areas of interest: occupational health, where I serve as the occupational medical consultant for Life EHS to Standard Bank South Africa. I'm also fortunate in that I'm a sub-investigator on the Pfizer BioNTech study at the South African site. I've also been assisting with consulting COVID-19 patients at GP and community level. If we now go into the topic itself, so if you just look a bit into definitions, so acute COVID-19, I'm sure now at just over 12 months of this pandemic in South Africa, we are well acquainted with this, the acute COVID-19, where we have an individual who's either come into contact with a confirmed or a suspected COVID case, or in some cases also when exposure is unknown, presents with what the commonly known symptoms of fevers, headaches, shortness of breath, chills, running stomach, vomiting, and subsequently goes on to have a nasal swab and test positive for COVID. This is what we would understand now as a classical acute COVID situation. In terms of long COVID, at the moment, there isn't yet international consensus of a definition of what long COVID is. But what, for our purposes of discussion, we're going to be looking at, the one is the National Institute of Health and Care Excellence from the UK, which talks about post-acute COVID or long COVID. And here they're talking about ongoing symptomatic COVID-19 where there's a persistence of signs and symptoms of COVID-19 from 4 to 12 weeks. And then a post-COVID-19 syndrome, which falls under that category, are signs and symptoms that develop during or after an infection consisting of COVID-19, persisting for more than 12 weeks and not explained by an alternative diagnosis. Our local NICD has also produced guidance which came out in about March 2021. And this is the definition we could use and easily applicable for us in this current situation and in this talk as well. Symptoms of COVID-19 being present beyond 28 days after the onset of COVID-19 infection. Also, in light of the lack of a international consensus of a definition from a medical perspective, the other terms used to reference the same condition, long COVID, you'd come across terms such as post-acute sequelae of SARS-CoV-2 infection, chronic COVID syndrome, or long-haul COVID. So that's in terms of the definitions. To try and get a sense of the scale of this situation, what I've got here are just summaries of 3 studies done in the UK, US, and China. The one on the left is a study done in the UK where individuals self-reported symptoms prospectively between 24th of March 2020 and 2nd September 2020 on a COVID symptom study app. And they had 4,182 COVID positive individuals that logged symptoms, 13% of which had symptoms persistent for more than 28 days, 5% more than symptoms persisting for more than 2 months, and around 2.3% had symptoms persisting for more than 3 months. And this is mainly in UK. So the 5% was those persistent symptoms over 2 months. The second study, which I've listed as well, it's a much smaller study. So this was done in the US. They had a total of 234 participants that were contacted in August and November of 2020 to complete a single follow-up questionnaire between the 3 and 9 months after illness onset. Of note here is that just around 84% of these were outpatients. So in our terms, these are individuals that would have had mild COVID. There were 177 COVID positive respondents. 11 were asymptomatic individuals, 150 had mild initial COVID, 16 had severe initial COVID infections. Of the 150 mild initial cases, 32% had reported persisting symptoms at around 5.5 months after illness, and a smaller number of 16 cases of severe initial COVID had 31% of them had persisting symptoms at a median of just over 5.5 months from the onset of illness. The last study, which I've also included here, is a study done in China between January and May of 2020 and looked at laboratory confirmed COVID-19 cases who were discharged from hospital. And the hospitalization could infer from that a moderate to severe COVID situation. So here they had 1,733 individuals who they looked at. 63% of them had reported fatigue and muscle weakness after symptom onset at a point 6 months down the line. 26% reported sleeping difficulties at around 6 months after symptom onset. 23% reported anxiety symptoms at around 6 months. Further looking, just looking but more into the scale and the statement that came out in the Lancet in an article that came out in December 2020, where through the coronavirus infection survey, around 1 in 5 respondents testing positive for COVID-19 exhibited symptoms for a period of 5 weeks or longer. And 1 in 10 respondents testing positive for COVID exhibited symptoms for a period of 12 weeks or longer. So they estimated that during the week commencing the 22nd November 2020, around 186,000 people in private households were experiencing symptoms of long COVID. So now we need to try to get a sense of the scale within our own context. And I've put together this little slide here. What we do know of COVID on the left-hand side is those that are infected, and around 80% of them would go on to have mild COVID, 20% of them would go on to have moderate to severe COVID. And currently our case fatality rate, we're sitting at around 3.4% based on the data, the recent data. So the question obviously comes about in terms of long COVID, what could it or would it look like in our own context? Are we looking like a 1 in X situation, a 1 in 5, or 1 in 10, as we try and compare ourselves to what's emerging from data in the UK? And I think as data is being collected and understood, the picture will become more clearer. So where we stand at the moment in South Africa is just over 1.5 million positive cases identified, just over 1.4 million recoveries and 53,356 deaths. I think the important point to understand from this is that we probably would have encountered these entities already, and be sure to see it as well within our social as well as work environments. So now we'll chat a little bit about the clinical characteristics of a long COVID situation. So an important point I would like to raise is that similar post-infection pictures were seen with prior coronavirus outbreaks. So with SARS and MERS outbreaks, post-illness, individuals are noted to have reduced lung function and reduced exercise capacity at 6 months after discharge from hospital. Persistence of mental health problems, including post-traumatic stress disorder, anxiety, and depression, also observe around 1/3 of survivors at 12 months after discharge. And the quality of life was observed to be low even 1 year after discharge from hospital. In terms of our SARS-CoV-2 pandemic at the moment, or the COVID pandemic, what we do know in terms of complications that can occur, definitely long-term, acute respiratory distress syndromes, arrhythmias, myocardial injury from a cardiac point of view, renal injuries can occur, acute kidney injuries. The neurological system can also be affected, neuropathy, encephalopathy, and musculoskeletal weakness, pain, fatigues, etc. An important point to just remember with the long COVID is that what is becoming evident is in many situations the actual clinical signs can in instances be related to objective clinical findings, but also there are circumstances under which the symptoms are present and no abnormalities can be found at a clinical level. That's important to keep in mind. I've just summarized, given a broad overview in terms of some of the clinical characteristics as well. Common presentations include fatigue, exhaustion, and cognitive aberrations. Important to also remember that affected patients may dismiss the clinical picture as non-consequential. So if you had to try and put ourselves in this position, and some of you may have experienced it as well, if a person has been through a significant illness like a COVID infection, even if it's mild, moderate, sometimes even with the mild cases, there's with the anxiety around having a COVID-19 infection, and once you're out of that acute phase, persistence of subtle symptoms may easily be passed off as of being of no consequence, and as a result of it, could be missed. And we've seen it, and I've actually seen it in clinical practice. And as this entity is becoming more and more defined, the population, patients are also becoming more educated on this particular matter. Long COVID is also more likely to occur following a serious infection, but please keep in mind that it can occur after mild cases of COVID as well. And as it alluded to, it can be associated with or linked to objective clinical abnormalities or findings, and also there could be no objective clinical findings could be found, which could explain presenting symptoms and signs. And commonly with the long COVID picture, what the information is coming up with is that it's commonly 3 or more symptoms or signs at presentation. So this is just to give you a broad picture. This is not comprehensive. This is just some of the symptoms on the left. You'd see actual presentation of complaints or symptoms an affected person would experience. Example of these being the loss of smell, taste, sore throat, coughing, shortness of breath, chest pain, chest heaviness, pressure, joint pain, muscle pain, weakness. From the neurological side, the headaches, dizziness, cognitive blunting, brain fog, and then also the low mood, anxiety, delirium, difficulty sleeping. More systemic symptoms, for example, fever, low-grade fevers, fatigue, and from a dermatological side, rashes, also gastrointestinal upsets. On the right side, are actual objective abnormalities which could be seen with long COVID. And again, keep in mind that in some situations, no abnormalities may be found in individuals with long COVID. So ischemic stroke, seizures, encephalitis, cranial neuropathies, myocarditis, pericarditis, liver kidney dysfunctions, post-traumatic stress disorder, the myalgias, multi-system inflammatory syndromes. So it's a wide variety and spectrum of issues that could come up. And functionally, the presentations could obviously be very vastly and vast and varied. This is a self-reported survey as well that was done by University of a social media survey done by University of Southampton. And here it looked at both the lab confirmed and not lab confirmed COVID situations where the respondents had reported symptoms. And as you can see, the vast array of issues reported, vomiting, sneezing, fever, loss of appetite, skin rash, etc., right down to anxiety. And right at the bottom of the slide, one could see the more common presentations of exhaustion, cognitive dysfunction, breathlessness, headache, palpitations, chest tightness. So just to share some of my own experiences of cases that I've been involved with, and this is just a four of them. The one is in current context, 31-year-old female, 6 months post moderate COVID-19, who has persistent but decreasing brain fog, fatigue, shortness of breath, hair loss. And her husband, a 31-year-old male, 31-year-old, also 6 months post COVID-19, complaints of persistent fatigue and currently under investigation for an unexplained swelling of both arms. Another example is a 56-year-old male team leader with COVID in July of 2020 and presented to us around about February. He had comorbidities of hypertension and presented with fatigue, shortness of breath, and a particular functional complaint in terms of his work situation. He found it difficult to maintain focused as he used to be able to. He had experienced a loss of train of thought during meetings and a feeling of that he has a deficit in his short-term memory. The other case was, this is a 67-year-old male who had a number of comorbidities of diabetes, hypertension, and myocardial infarction, pre-COVID infection. It contracted COVID-19 around about November 2020. And now about, say, 5 months later, presented an aggravated severe cardiac failure and had to be referred on for further management. So, in terms of what to do, in terms of what could be done in terms of management of this kind of situation, the NICD is also looking at this, and we could look at some of the guidelines published from the NICD. The NICE UK guidelines also do provide good frameworks to consult and to set up management strategies. But what I wanted to do is just touch on a very broad approach one could consider or implement. And this is using a validated questionnaire, example, the COVID-19 Yorkshire Rehab Screen, as a telemedicine telephonic interview, and doing it at 4 weekly intervals post-symptom onset. So using this kind of a screening tool, and has to be applied by a medical or a health professional, one could identify cases that need further investigation. And the option here to refer cases for face-to-face medical assessment for the identified cases of concern. And at that level, then any cases could be then either then managed to care to a point of well-being or referred on for further investigation. Ideally, the management has to involve a multidisciplinary team, and based on what the NICE UK guidelines talk about in terms of what would be an ideal multidisciplinary team, or MDT, you look at having a physiotherapist on the board, helping with pulmonary rehabilitation, improving mobility and stamina, fatigue management, occupational therapists, where they could help with improving activities of daily living, fatigue management, and vocational rehabilitation, which obviously is important in our context. Speech and language therapists, they're helping with swallowing, voice, and cognitive communication, a dietitian, psychologist, and a physician or a general practitioner with specialist interest in rehabilitation. So this would constitute, what would be an ideal multidisciplinary team to manage these kind of situations. In terms of current challenges, important to know that, patients may not recognize the subtle symptoms and signs of long COVID as an abnormality, and may therefore not seek help to manage further. If it gets passed off, it's nothing serious and it's just this subtle aberrations. For example, the case that I gave of the 56-year-old gentleman who had the COVID around about July of last year and actually raised it as a complaint in about February of this year. Another situation which we face not only in South Africa but internationally as well, even in the UK, many mild COVID cases may not have gone for confirmatory testing. So this creates a problem where long COVID presents without a preceding or confirmed diagnosis of COVID-19 infection, especially considering that it could occur after a mild infection as well. And together with that, a sub-point is that not all moderate and severe cases have been managed within the hospital setting in South Africa. Moderate cases have also been managed in primary healthcare settings. That's the challenges that we face. So thank you. And over to you, Sungula. Thank you for that.
Thank you very much, Dr. Salim. I think that was a very insightful presentation that I think opens a lot of our eyes with regard to what long COVID is. And it sounds to me like, there's a lot that we don't know, rather, that the research is still coming in about what that is exactly. So before I hand over to Myrna, who is going to discuss what the implications are in long COVID for HR professionals and employers in general, I've got a poll for our participants to participate in, which is asking really how has COVID impacted absenteeism within your organization? It's a simple yes or no question. The alternative answer is we're not sure. We haven't really been tracking absenteeism since people are working from work. So I'm really looking forward to seeing what the results of that are going to be. And I think Myrna is going to touch on the results of the poll in her presentation. So without further ado, Myrna, I'm going to hand over to you. Please let us know, what does all of this mean for employers and HR professionals who really have to have their finger on the pulse when it comes to how these health matters impact employees. Over to you.
Thank you very, very much, Ngulip. Just can you see my slides, and is it in the correct view mode? Just checking
yes, that. It is perfect.
Perfect.
Proceed.
Okay, thank you very much. And thank you to Dr. Salim for his insightful presentation. I think he's given us a good clinical overview of what long COVID is. I am going to, within my presentation, have some overlap, but I think it's important to reiterate some of those comments. So I am Head of Health Management Solutions at Alexander Forbes Health. I'm an occupational therapist by profession and have been working within the health risk management space for the past 25, 26 years. So if we look at long COVID, let me just try and move my slides. They don't want to. There we go. We, as Dr. Salim said, 1 year after the outbreak, and some patients who recovered from an acute illness, they didn't have severe symptoms, are now struggling with long-term consequences. And a lot of them are pushing it aside. They don't know what it is. They're just carrying on without actually looking at it properly and treating those symptoms. And we'll come into that just now. What has been noted that if new or ongoing symptoms occur, they can change unpredictably. So they were never tired or they didn't have certain conditions when they actually had COVID. Now all of a sudden, new symptoms are arising. And also it doesn't appear to only be linked to people who had severe COVID or who were in ICU or were even in hospital. People with mild or no symptoms are starting to feel the effects of long COVID. There's been a lot of research, as Dr. Salim has alluded to also in his book, so I won't go into too much detail, but there's a current app which showed that 1 in 22 people who had COVID had symptoms for longer than 8 weeks. That's quite substantial, and they looked at 4 million users of this app. And then the Lancet Medical Journal also has done a whole lot of studies, and 1 in 10 people have got symptoms post 10 weeks. So it definitely is a significant impact, and there's a definite impact on our overall working performance. And I think you as HR practitioners are going to start seeing it more and more within the workplace. And especially now, people are starting to come back to work. We are still working remotely, but there is still that face-to-face interaction as well. The one thing with long COVID that we need to remember is that there's no clear treatment pathway. We're treating the symptoms. We don't know, and it's so new. We don't know how long this is going to carry on for. And there is minimal evidence, but it's evolving. New studies come up all the time with what's happening. This is just a picture of people suffering 83 days, 58 days, 62 days. Most people recover within 2 weeks without treatment, but a lot are feeling the long-term effects. As Dr. Salim noted, it manifests in varying degrees of severity, and they can disappear and then reoccur later. And I think that's what the uncertainty is that once you've recovered from COVID, you don't know if you're going to get those signs and symptoms again. It affects your health and your quality of life. There's definitely a decline. What is interesting is that what they found is that it's very similar. The symptoms, the signs, the effects of it are very similar to autoimmune conditions. And there's an increase in inflammatory markers. And as we said, there's fatigue, cough, shortness of breath, inflammation, and injury of major organs. And then the neurological and the psychological effects. I think the psychological effects are sometimes the more difficult ones. Mood swings is another thing, which within the workplace, we're going to have to manage that. Memory loss, brain fog, forgetfulness, tired exhaustion. What we're picking up is that fatigue is one of the main indications of long COVID, and people are feeling that fatigue long term. I'm not going to go into the studies because I think Dr. has gone into quite a few studies already, but just that you are aware, new studies are coming up all the time, and the evidence is there. This is not something that is hearsay. The evidence is there. And within the South African experience, 63% of people with long COVID have reported muscle weakness and fatigue 6 months post-infection. That's a long time infection. I personally know people who 8, 9, 10 months later are still struggling. So if we look at the primary factors influencing our return to work, which is where we as HR practitioners need to actually be cognizant of, as I said, fatigue and persistent symptoms, which is a big thing. But then there's also the mental health factors, anxiety, post-traumatic stress disorder, depression, sleep disorder. It always a part in this. What's happening also, especially with those who had severe COVID, were in ICU, on ventilators, or just hospitalized, that post-traumatic stress is real. And it's a concern that we need to look out for. And we need to mental health has been an issue throughout lockdown. This is just another phenomenon now that we need to look at and be cognizant of when talking to our employees. There's also the employee has the sense of that they feel that they're not meeting their client or their employer's expectations. So that causes extra anxiety. and leads to depression at the end of the day also. So they need, and I'll cover it just now, there needs to be a partnership, and we need to be working together, and we need to be listening to what our employees are doing. From the PTSD and the depression, which is not you can't see it. And I think that's always been an issue when it comes to incapacity in the workplace, is that a physical disability you can see and you understand it, whereas your psychological conditions, the person looks normal. So people think, well, what's wrong? They should be able to do what they're doing, but they actually can't. There's an impact on working efficiently, driving, if driving is part of their job requirements, managing their finances, making informed decisions, and even on their daily family activities. And I know we say we come to work, you can't leave your home situation at home. It comes with you to work. So we need to make sure that we're assisting them actually manage themselves holistically. And the impact on behavior, which is the last part of the factors influencing return to work, is the fear and uncertainty. And it's that fear of the unknown. And they don't know when they're going to get better. It's the same as those suffering from ME, for example. They actually don't know how long the symptoms are going to be there for. So it becomes quite stressful and anxiety driven. And no one is the same. We all react differently to different stresses, and we need to remember that. So as I said just now, the employees' concern is they may not understand or recognize what's happening. And as Dr. Salim said earlier, they play down the symptoms. They don't realize they actually need to go have it seen to, and they need to actually treat those symptoms. And it's not normal to be fatigued for so long. And it has an impact on their well-being as a whole and their ability to cope. And often they come back to work too early because there's that sense that they have to. If they don't come back to work, they're going to lose their job, especially in companies where there is a financial strain already. So they tend to not look after themselves or look out for those symptoms, but come back to work too soon. And I'll go into it just now also. It talks to the whole absenteeism in the workplace and presenteeism in the workplace, and people working while they're sick. So they might be present, but are they really present? And are they really there? And are they really concentrating? So just some interventions that we need to look at. Acknowledge and be a witness. As an HR practitioner or line manager or supervisor, we need to acknowledge it. We need to honor the experience, understand that they are going through this. We mustn't, as the HR person or the manager, push it aside and say that it's all in your head, it's nonsense, carry on. We need to acknowledge it. It's not a typical return to work planning. Although we don't need to put new policies in place, if you have an incapacity policy in place, you follow that same process. Integrated or facilitated return to work. Can they do their job? Can't they? Do they need accommodations in the workplace or not? So actually looking at all of that and managing the expectations. And it's the expectation of the employee and the expectation of the employer. So it's managing both and managing them together as a partnership. Making sure we actually understand the residual impairments. What can the person do? What can't they do? Make sure that they actually go for a proper functional evaluation to actually ascertain whether they should be in the workplace or not. Should they be on temporary disability, or should they be on a graded or facilitated return to work, or should they be in an accommodated position? So we need to understand all of that and understand the job demands and the job requirements. How stressful is this job? Can the person still do it? Will they meet those deadlines? How can we support them? And adaptability is key. I want to say it's a moving target. It is a moving target because we don't know, it's so uncertain because it is so new. So we don't know. So how do we support employees who've had symptoms for longer than 8 weeks? Make sure that it's a graded or facilitated return to work, pacing, goal setting, participation, meeting with them. A return to work interview must take place so we can actually set the goals for everybody. And then everybody understands what is required. Be patient. Okay, we can't put the stresses of the job demand onto the person as well. We need to be patient and understand that we don't know when the symptoms will dissipate. Mental health care is important, and I'll come into it just now as well. From an employee wellness perspective, it needs to be coupled with the graded return to work. Support services and resources, a facilitated reintegration, especially into driving, back into driving, even if it's not for work. Meaningful activities, return to work. Sorry about that. Empowering self-efficiency. The person needs to take care of themselves. If I don't take care of myself, nobody will. And we must also celebrate the small wins. So don't forget about the small things that the person manages to do. We must celebrate them. And I've said this in many of my talks before, and I have spoken before in this platform. Clear, honest, open communication with the employer and the employee early on. If we look at telephonic and virtual support, which Dr. Salim mentioned as well, it's definitely been proved to be successful. And it's successful in understanding symptoms, impact on productivity, accommodations that are required, or if the person needs to go for follow-up treatments. We need to make sure that that contact and that support is there continually. If we look at how to overcome the concerns of the manager and the employee, I just want to check if I'm running out of time, sorry. The manager and the employee, we need to make sure that there are early intervention and monitoring processes in place. It doesn't help if you've got a person in the workplace who's been struggling and we're not actually picking it up early, because all that does is causes a domino effect. And the person isn't going to recover, and their team members start actually taking on additional work to support them. Make sure that telephonic or virtual check-ins are happening weekly, daily, depending on the situation or how severe the long COVID effects are. Support must be offered to assist with any short-term difficulties, as we've said before. In terms of longer-term management, what we need to look at now is, can the person come back to work? Yes, no. How long will they be off for? Do we need to look at disability benefits if it's longer than your waiting period? All those things need to be taken into account. Do we need to refer them for further medical intervention? And then cross-referral between EAP, your medical scheme, any employee well-being support that you have internally. There has to be discussions and communication amongst everybody so that you can support the employee holistically. How do we identify employees at risk? So I know we did the poll earlier, and I'll look at the answers just now. I can't see it now. We need to look at our absenteeism data. The problem is that absenteeism data during lockdown, people were already at home. So people were already at home, so they weren't taking sick leave. So if they were sick, what happened was they'd work a bit, they'd go lie down, they'd carry on working, they'd go lie down. So they never recovered fully. So they just took longer to get better. So I'm going to show you my next slide just now. When we look at the actual absenteeism stats that came out for 2021 from our clients, which actually is quite significant in the management of absenteeism. From the poll, what we saw was that 37% said that COVID has increased absenteeism in the workplace. 24% said no, and 39% said not sure because we're not tracking absenteeism per se. So if I can, I'm going to go to my next slide and then I'll come back to this slide. It doesn't want to move. If we look at this, it's actually quite significant to note. We've taken from 2017 to 2020 stats from some of our clients, not all, but a large proportion of our clients. In 2017, the sick absence ratios were sitting at 2.16. In 2019, it was 2.22. In 2020, they dropped significantly to 1.63. So your sick absence ratios, and if you look at the actual graphs here, you notice the steep drop and the steep decline. And in the first 3 months of 2021, it's gone to 2.42, which is even higher than it was prior to COVID, which shows now we're now going to start seeing the impact of long COVID and COVID on absenteeism, which is quite interesting to note. And it's something that as HR, we need to be cognizant of and we need to take note of. And you need to make sure that you are managing and monitoring your absenteeism in the workplace, even virtually. People who are validly sick need to switch off and get better. But what we're also finding during this period, there was a lot of opportunistic utilization, but it wasn't monitored and people didn't put in that sick leave. So all it does is it adds to the bottom line. Your cost of sick leave increases substantially because people, instead of taking leave when they should, they actually have more leave to take later on. And often they see that the 36 or 30 days as a benefit. And I need to make sure that I take all my leave before the end of a 3-year cycle. So these stats are quite alarming, and it's something we as Alexander Forbes Health Management Solutions are monitoring quite consistently now with our clients on a month-to-month basis to look at the sick absence ratios and look if it's going to stabilize or if it's going to continue to increase. So just how do we identify employees at risk? Okay, as you need to look at your absenteeism data. You need to look at the parallel process to long COVID incident data and normal absenteeism and understand the impact that the pandemic has had on our absenteeism. So employers are advised to adopt a holistic approach to managing long COVID in the workplace. And the parties that need to be part of this are your occupational health, absenteeism and incapacity investigation and management, your employee assistance support, and then your return to work strategy process through work accommodations and graded or facilitated return to work. And they all need to talk to each other, and it needs to be interwoven. I'm going to stop sharing my slides so I can actually see if there are any questions in the chat box that I can answer now. Or Sangula, I'm happy to hand over back to you. I hope I've given you a good indication of where we are. It's uncertain. As Dr. Salim will say also, we don't know what tomorrow brings. So we don't know how long this is going to be with us, but we need to make sure that our policies are in place to manage it correctly. Thank you.
All right, thank you. Thank you very much, Myrna, for that. Also quite a detailed presentation on what HR professionals need to be aware of with regards to long COVID and the impact on absenteeism and performance, respectively. We're now entering the Q&A portion of the discussion, and I'd like to encourage you all to really drop some questions into the box. We do have a few that we're going to get into right now. Before we do go into the questions, I'm going to set up another poll just to get the conversation going. And I'd like to find out from our participants, what has been the incidence of long COVID in your respective organizations? I'd like to know, if you've had people, has it been a lot? Has it affected your organization to the point that you're very concerned about it? Or if not, tell us why. So that's what that poll is about. And while we're waiting for those results, I'm going to get into the questions, of which we have a couple. One is from my colleague, Georgina Guedes, who asks, with both severe COVID requiring hospitalization and long COVID, does the patient remain in any way infectious beyond those first 2 weeks? Or are the symptoms just because of damage to the body and not an actual ongoing infection? I think this one is for you, Dr. Salim. How long does a patient remain infectious, whether they have long COVID or not?
So an important way to look at the situation is that the long COVID presentation is not related to the presence of, in general, presence of virus within an individual. So they're not having an active disease. There isn't active virus. So long COVID should not be equated with infectivity in any way. It's more the post-acute consequences of the sequelae of it. So I hope that answers that particular question. In terms of actual durations, etc., generally a mild COVID, with the definitions have been given from the NICDS in terms of the effectivity period, up to about 10 days post-infection, 3 days post-recovery of severe symptoms. More longer-term patients with more significant illness, it will depend on their stay in the ICU and post-discharge, but generally on discharge, they are not infective. But for the purposes of this discussion, long COVID should not be associated with any degree or risk of infectivity.
Okay, and then for you, Myrna, as a question for me really, and it's with regard to the impact of COVID on insurance premiums for organizations. We've seen with a lot of death claims, the insurance premiums on that side have been impacted due to the high incidence of claims. But what does it mean for the insurance benefits that employees provide to employers in the long term? Do you think that it'll be affected?
Yeah, thank you very much, Sangula. And I see someone has also posted something very similar in the chat. Could it lead to disability claims? The answer is yes, and we don't know how long COVID is going to be here for. That's why I think they're also calling it long haul, because it is a long haul. And because it's something so new, we don't know if the person will recover or won't. We like to think that they will. And also, if we treat the symptoms, we can get a better management of it. It will. Insurance companies are already seeing an increase in disability claims coming in. So I do think it will have an impact. So what companies need to do is we need to manage it upfront. And that's why employees mustn't, if they have symptoms or they feel like they have symptoms, we need to manage the incapacity within the workplace and see if we can't accommodate them or facilitate accommodations, graded return to work or facilitated return to work to actually prevent the longer term disability. We don't want a population of 30 to 50-year-olds on disability. You want them productively employed in the workplace. So what we need to try to do as employers is actually find that tool where we can actually have them productive in the workplace. And with some of the symptoms, they might have symptoms and it might be long term, but you can still work and you can still be productive. It's just the how.
Relating to what you're talking about there is we have a question from City Dabula, who's the HR director at Lafarge, and she's asking for advice on how to deal with employees who have comorbidities that refuse to be COVID vaccinated, but are also unable to work from home due to the nature of their work. Does that mean the employer is the employer liable to keep them employed and pay them even though they refuse to be vaccinated? I know it's a little bit deviates a little bit from the topic of long COVID, but I'm wondering if you have some answers for our community member.
Yeah, that's a very good question, I have to say. And vaccinations at the moment are very much in the media, on everyone's top of mind. I mean, especially now with the pausing of the J&J vaccination, I think it's very topical. We cannot force our employees to go for vaccinations. There's no South African law and freedom of choice does not allow us to force employees to go for vaccinations. So we've got to be careful with that, because it can't be seen from a labor practice point of view that because you haven't been vaccinated, I can't employ you. So we've got to be careful of that. However, with the comorbidities and people who are vulnerable and cannot come back to work, the numbers are low. So they actually, we do a lot of vulnerable employee assessments for a lot of our clients. And as long as the person is working in a safe environment and not in crowds and COVID protocols are met, they actually should be able to return to the workplace if that's where they need to be. A lot of them are still working from home, and a lot of jobs you can do from home. Unfortunately, within retail, manufacturing, you can't be a cashier sitting at home, but you can do your desk job sitting at home. So depending on the job, we would actually look at what the job is. Does the person have to be in the office or not? And if yes, as long as COVID protocols are taking place, that person should be able to come back to the workplace. And if so, Dr. Salim wants to add something after this. So the employer can then have that conversation with the employee and discuss that if the employee refuses totally and there's no reason why they shouldn't be able to, then it's more of an ER issue rather than a medical issue.
Yeah, just to help with them, to add in there, I think there's the occupational health aspects, which is about the controlling and managing of risks, which I'm sure everybody is well versed with. In terms of a situation as highlighted, yes, that is a complex area. And in terms of the legal frameworks, I would invite the legal consultant to provide the actual perspectives as to what's doable, not doable. But again, as Myrna said, as the employees cannot be forced, it's their right and their choice as to whether they'd opt in or not want to, whether they agree or not agree to want to take a vaccination. But it's a complex question. I think it requires a multi-stakeholder involvement to thresh out and answer based on the various industries and their work requirements.
Okay. The next question is from Val Littlewood, who has become a bit of a regular on our webinars, and we appreciate your contributions very much, Val. Val is asking, well, she says rather that she has a heart condition that presents with all of the COVID questions, in inverted commas. And from a work perspective, how would you manage the checks to ensure that they are not infected? Also, can you be infected more than once? It's not clear what you're asking here, Val, but I think what you're alluding to is that perhaps you've had COVID in the past and you have a heart condition that has that means you still have a lot of the symptoms presenting, and you're wondering how the employer can ensure that colleagues are not infected. If I'm not mistaken, you can clear it up in the chat there, Val. But can Dr. Salim?
Let me come in there. I think I'll consider this to be an example and not a person with a condition because of medical confidentiality. So let's just take it as a scenario. So to talk to one or two of those questions, can a person be infected more than once? Definitely yes. And in terms of how would you manage the checks to ensure that they are not infected, it's very, very case specific, and you need to break down the various scenarios of what it could be to be able to design a screening program and how that would fit in. Yeah, and I would leave it, and I'd consider it as not being specific to a specific individual right now because of medical confidentiality.
Yes, I see that Val has just responded in the chat. It was referring to the screening questions that were asked earlier, and that because of her heart condition, Val would really present with COVID because the symptoms would mean that she'd answer yes to a lot of the screening questions. And that would not be because of COVID, but rather because of her heart condition. So then how do you address that issue?
Yeah,
I can just answer. Sorry, Dr. Salim, I'll hand to you now. Sorry, apologies for that. I can just answer here. It's very much, as Dr. Ahmed said earlier, also it's very case specific. So if you're answering yes to all those questions, I know from my own experience, if I answered yes to any of the questions, I would get an email back from the business asking for clarity. And then explaining it and asking if you're aware of X, Y, Z. So it's very much a one-on-one, and it'll be a one-on-one discussion. So we wouldn't automatically assume because you're answering yes that you we suspect that you have COVID. So it would be more of then a question and answer session or a discussion to ascertain what is really going on. Dr. Salim?
Yeah, I think it's a complex situation if a particular condition is known to cause particular signs and symptoms which overlap with the signs and symptoms of COVID. It has to be taken via the occupational medical practitioner on site and have that particular case specifically managed within its own context. But again, just a reminder, please, let's just keep our medical information confidential as well, please.
Okay. And then I think I'll ask one more, which is also for myself, and that's with regard to the third wave. A lot of people are concerned that, with winter on the horizon, the third wave of COVID-19 infection is going to be on the rise. What are you seeing on the ground, Dr. Salim, in terms of what Life EHS clients are concerned about regarding the third wave, and how are you kind of advising them in that regard?
Sure. In terms of the approach given, so the key factors is the standard safety protocols to prevent and mitigate. These do work, and you can just apply logic to it. Staying away from an infected person, so the social distancing, critical. Sanitizing, wiping sanitizing the hands whenever you're coming into contact with any surface or any type of potential source or any risk. And that's one of the routes where it could enter into the body. So sanitizing, very important. Masking, very important. So we're now 13 months into the pandemic, and we've all felt it, and I felt it myself, the fatigue in terms of complying with the safety protocols, but the standard safety protocols, maintain it, keep it up. That's critical. In terms of the third wave, not specifically season related, and we haven't yet got news as such. The NICD hasn't given us any guidance in terms of, put out any data to indicate that there is, or we're entering into a third wave as yet. So just keep an eye on those numbers, and we follow the guidance as given by the NICD on that particular topic. I hope it helps.
All right, it does. I think it does. And then one more question, again, from my colleague Georgie. She asks, regarding long-term COVID, we don't know when the symptoms will dissipate, but she's asking, do we know for sure whether they will ever dissipate at all, or with these symptoms that could present in perpetuity rather? Does the research speak to anything of, there being a date where a patient could be completely healed, or do we not know? And does this then have implications for disability claims and, chronic meds and so forth?
So giving a clinical perspective again, if we go back to the pathology or the pathomechanism, some cases of long COVID can be linked to identifiable pathologies. So that will be, for example, a person with a myocarditis or develops a cardiomyopathy or had a myocardial infarction, where there is that kind of issue when you have a functional consequence. You could then understand what the functional implications are, medium, long term, etc. Then there's the other category where it cannot be linked to any specific clinical cause or pathology. And in those situations, it's a known unknown, something that time will tell.
All right, that brings us to the end of today's webinar. I'd like to thank all our guests for coming to join us and giving us a very insightful discussion about what long COVID is and what the implications are for employers and HR professionals in general. Thank you, Myrna and Dr. Salim, for really spending this time with us. Before we close, I'd like to let you all know that we have another webinar tomorrow at 11 a.m. where we'll be discussing zero talent waste and the pathway to uncapped recruitment. The webinar, which is sponsored by HFM Talent Index, is really going to delve into all the ways you can make sure that you waste no expense when it comes to your recruitment activities. Thereafter, we have one scheduled for the 21st of April, where we're going to be discussing again with regard to recruitment, artificial intelligence, and how you can incorporate technology and human and robot super teams to an evolving talent acquisition discussion. Our guests will be Heidi Komula, Ndifo Nefumbana, and Walter Huber. So without further ado, thank you very much. It's been a very insightful conversation, and I look forward to seeing you at our next webinar. Thank you all very much.
Thank you very much. Thank you.
Fantastic.